if you treat people with moderate COVID with ivermectin, within 24 hours, the oxygen saturation can increase dramatically. Now, no one had an explanation for this. First of all, people couldn't understand why it was people who didn't appear very sick, but had COVID early on, had very low oxygen saturations, well in the 80s. It should be up, 94, 95, 96. And when you treat them with ivermectin, over 24 hours, this would pop back to normal. And what David and some of his colleagues did in France was they showed that if you take the virus and mix it with red blood cells, they all clump together. And so it started making sense that if you had moderately severe COVID and the virus was getting out into the gas exchange part of the lungs, it would clump those cells so that they couldn't efficiently take up oxygen, because that's the job of the lung, to put oxygen into the body and carbon dioxide out. So, and then what they did was very clever. They put ivermectin into the system, and suddenly you could stop this aggregation. In other words, ivermectin, and other people had been showing that ivermectin tightly binds to spike protein. So here you had a situation where the spike protein on the virus was able to clump these cells, causing low oxygen in the body. Ivermectin could actually prevent that completely. And that fitted with the clinical observation that by treating people with low oxygen, it came back to normal. And this changed the way I think people should be thinking about ivermectin. And that is that ivermectin works not just late in controlling the viral replication, but also very early by acting, if you like putting a clamp over the top of the spike protein so it can't do damage. And so a number of us, I'm not the only one who did this, is doing this, and you put up a graph which was the first patient that I actually treated who had got post-vaccine damage of the long COVID type. This particular young boy was immobilized. He was found outside of a building by one of my colleagues, Tom Barodi. Tom saw this guy, but he couldn't even stand up. He had what's called POTS syndrome, which is a type of the damage that you can get following vaccination. But an absolute classic case. Anyway, we treated him with ivermectin, knowing about this new mechanism that had been described, and I make sure that all my patients do what I call visual analog scale. They take each symptom, and what you're seeing on that graph, and this is a graph that I had nothing to do, this was done by this young university student, and I asked them to grade every symptom 0 to 5 twice a week before they start the ivermectin, and you can see that after about 2 weeks, basically all those symptoms are nearly right down the bottom, which is close to normal. Now, the sad thing was that after a week, then he stopped the treatment and the symptoms started coming back. Now, the follow-up of this young fellow is he's now back at university doing extremely well. We reintroduced ivermectin. He's titrated that against what he needs to get acceptable treatment. If he stops the treatment, the symptoms come back. And I think you were telling me off camera, John, that you've had experience talking to patients with very similar types of stories. Now, we've obviously treated quite a few patients now this way, and they pretty much, if it's a clear-cut story of either post-COVID infection or post-COVID vaccination, pretty much, if not all, certainly not all, there's one or two that haven't, but most of these people get a graph like this. Now, they're not always quite as good as this, but most of them have significant improvement. And what I think is happening here is that the ivermectin is capping the expression of the spike protein throughout the body on the various cells. Now, the symptoms that improve quickly are the ones that relate to non-tissue damage. A lot of the people we see get what's called small fiber neuropathy. That is, it's not the big whole nerve that gets destroyed, but the very small fibers. And that usually they have burning feet. I had a lady yesterday who had burning hands, and then she got burning feet. But they, in our experience, many of them do improve, but it takes much longer. It might be a month or 6 weeks or 8 weeks. And again, because we can't quite get people to do large randomized controlled trials, you're not totally certain of whether some of those effects are the natural history of gradual improvement. As we know.
No, I'm convinced by your cohorts of patients, Robert, and consistency with other physicians I've had the pleasure of talking to around the world, that the picture is consistent. Here you've got rapid reduction in chest pain, passing out, this POTS syndrome, the fatigue, the brain cloudiness, the brain fog, all improving dramatically. How long after starting the ivermectin did these symptoms improve in this young man?
Well, you can see that on the graph, John. I think it's about 10 days to 2 weeks before you can see, as I'm looking at it, the left side when the ivermectin was about to start, and then they're treated with the ivermectin for 10 days, 12 days, and then they plummet down to 0 or close to 0. And about 7 to 10 days later, we then stop. What I do is I give a 2-week trial, and then we stop the ivermectin, and pretty much all of them, again, exactly the same pattern. I know that I was talking to our colleagues in the States, where they've actually seen 3,000 patients like this, and they say that they see the same benefits. And most of their patients are post-vaccine as opposed to post-viral infection. I think you were saying.
Yeah, sorry. I was going to say you've actually got the double confirmation there. You've got the patient improving dramatically when you start them on the ivermectin. While they remain on the ivermectin, they stay improved. When you take the ivermectin away, the symptoms come back again.
That's true. That's true. It was interesting. I really followed the idea of that David in the States had pushed forward, and we've been fairly closely associated with that story. That this is what was happening, but in the back of your mind you say, well, is there something non-specific? And I saw a very important patient, actually also yesterday, that I think was important, was a patient that really had a vaccine, but the fatigue illness began about 6 or 8 months later. So the question I had is, can this person have a delayed sort of response? Now, this patient is the single patient that has had absolutely no benefit. And it's quite interesting that although we felt it was, from a medical viewpoint, a reasonable thing to try, because this person was so incapacitated, the patient didn't benefit. But again, it was very different to all the other patients we're seeing, where there's a clear-cut relationship between the insult, be it infection or vaccine, and the generation of their symptoms.
So this patient that didn't fit, Robert, he had the vaccine, then there was a long period of time that he was normal. What was the kind of history there?
He was a person who'd had a relapsing fatigue illness and came along and said, well, look, I think it might be all due to the vaccine, but I had the vaccine some months ago. I didn't actually, I've had a pretty good period of time, and now that all of a sudden the fatigue has come back. And we said, well, look, this is a bit different to what we're seeing, but let's see what happens. Nothing happened. Mm. So I think there's
two possibilities. Sorry, I was going to say there's two possibilities there, really, isn't there? One is that this is a delayed vaccine injury or presentation with a different pathophysiology. And of course, the other is it's not related to the vaccine at all.
Correct. And we were giving this a trial on the basis of the first of the ideas, that there was a delayed effect and the mechanism was similar to the other people that we were seeing.
Mm-hmm. Now, I think you've been thinking more about the genetics of these conditions as well, and again the commonality between the chronic fatigue and the post-vaccine and long COVID. What's your thinking about the genetics of this?
Well, what we noticed was in a lot of the patients that we were seeing with post-vaccine fatigue or post-infection fatigue had a history of episodes of fatigue illness. Now, it might have gone back years before. One person I had went back 20 years before when she was doing her final year exams at school, and I call it the HSC disease, because the final year exams here are called the Higher School Certificate. And when I was in more busy practice than I am these days, I would be seeing every year half a dozen young kids with this, and then they'd get through that and they'd be okay. Other people had a viral infection and it took them a year to get over it. So there was this story I was seeing in patients, and it suggested to me that there was a phenotype, a particular genetically influenced phenotype, a proneness to developing a fatigue illness when they're exposed to precipitating factors like a viral infection, a COVID vaccine, and it made a lot of sense. And then I started looking at markers that we generally used to see as being abnormal in people with chronic fatigue illness. And that is, did they have a slight defect in the antibody production by what we call a subclass deficiency? And I think it was a German group showed fairly recently that there's a significant what we call IgG2. If you look at antibodies in the blood, we say, oh, that's an IgG antibody. Now, if I can just go back a little bit of a step to explain this, that if you get a virus infection, you make progressively better antibody. You start off by making an IgM antibody. The names don't matter, but it's not a particularly good antibody to neutralize that virus. But the body's very smart. The T lymphocytes, remember there are B lymphocytes that make antibody, and then there are T lymphocytes that do other things. And we talked a bit about how they can damage the expression of spike protein on cells, causing structural damage. Now, the B lymphocyte then makes an IgM antibody, great big awkward sort of affair, but the T cell comes along and says, hey, this is not good enough. So it switches. The IgM goes down and an IgG antibody comes up. And that's the signature of having had a past infection. That will stay with you, perhaps for life. But when you look at the IgG antibody, it's also made up of different components, and they're called IgG subclasses. And there are 4 main subclasses, 1, 2, 3, and 4. Immunologists have no imagination. Anyway.
I could remember that, though, 1, 2, 3, and 4.
I can too. It's about the limit of my IQ these days. But so what we found in chronic fatigue syndrome is that people are fighting the infection with one arm behind their back. They have a reduced IgG2 or IgG3 subclass antibody. And what they do not switch from the IgM to the IgG. Now, I used to be so confused. I'd see people being sent to me by family doctors saying, what's going on? This person had glandular fever. You call it infectious mononucleosis. Most people now know that's the EB virus, the Epstein-Barr virus. And you make an IgM antibody. In fact, that's what you use to diagnose the infection. Oh, they've got an IgM antibody. And that disappears after a few weeks, and the IgG antibody comes. I'm seeing patients who have had fatigue following glandular fever, infectious mono infection, years before with both IgM and IgG. It was confusing. And what's happening here is that the T cells are defective, and this is allowing the persistence of this virus. In chronic fatigue syndromes, the persistent virus is the glandular fever, the Epstein-Barr virus. In post-COVID infection, it's the spike protein. And so you can start seeing that there's this common immune deficiency with genetic factors, the persistence of the antigen, be it a spike protein or a part of a virus, and an ineffective immune response, which is the inflammatory component causing the symptoms. And so one of the reasons for understanding all of these 3 components as expressions of the same generic type of problem is that a paradigm can be built up that explains and links them together. And so if there's a genetic factor, it may be that if you're getting a problem with glandular fever virus, sorry for those who don't live in Australia, Epstein-Barr virus, that you make an incomplete immune response and you get over it, sort of get over it, and then come along and you get COVID. Well, the same sort of genetic immune defect is there, and so you get the problem. Now, I've been finding in a number of the patients with post-COVID fatigue illnesses that they've got an IgG subclass deficiency, many of them do, and many of them still have the signature of a defective response to the Epstein-Barr virus by still having an IgM, IgG combination of antibodies saying, hey, I've got a phenotype, I'm around to get problems if I run into COVID. Now, to me, this is incredibly important because, should we be vaccinating those patients? Should we be doing these simple screening tests? I don't know the answer. These are issues that the people who have access to large funding things, they should be looking at this. And when we started talking, I was talking about the great disappointment of the outcome of our review, government-initiated review of long COVID, where none of this sort of aspect was looked at. It was all very superficial stuff. We need rehab, more rehab. So they put $100 million into that sort of research, not a statement about let's looking at what's going on and how we can understand and maximize the benefits by looking broadly at this issue of phenotypic fatigue illness syndromes, if you like.
So quite a few of the patients that you're seeing with post-vaccine long COVID, whatever we want to call these two things, quite a few of them still have IgM, immunoglobulin type N to M, to Epstein-Barr virus.
Not quite a few, but some.
Some, yeah. And are you seeing IgM?
Quite a few who have IgG subclass deficiencies.
Yes, right. And are you seeing ongoing IgM2 spike protein as well? Do we know that?
That's the absolute obvious question, and unfortunately, the routine pathology labs don't do that as a routine. I wish they did. My problem, of course, is that in the past I had a laboratory with something like up to 60 scientists, and I could simply say, look, guys, just go and do an IgM antibody, but I'm seriously old these days, John, and I don't have that laboratory access anymore because I've retired from the university. But that's desperately needed, and so easy to do.
Yeah, it's just so obvious. I mean, well, if I can think of it, it's got to be totally obvious. It's
yeah, but yeah. I think to properly answer the question you asked, which was the genetic aspect, we have to look at what I think is very exciting, and that is the current what's called computational genetics. Now, if we look at genetics, we understand there's DNA, there's messenger RNA, there's expression on proteins, and if we go back to Mendelian genetics, people were looking at big chunks of genetic change so that you didn't get that gene, you got a rare disease. It could be phenylketonuria, all these things little kids can get.
Single gene conditions very often.
A single gene causing a disease. But of course, things changed when in the early 2000s we brought in using PCR technologies, you could start analysing genetics. And this, of course, led to the Human Genome Project. And we started looking at what's called SNPs. SNPs were identifying a single genetic defect that may not lead to albinism or some major disease, but could influence the outcome of a disease. And these were called single base replacements. So you've got these four base components in DNA or RNA, and if one of them was just missing, it could not necessarily lead by itself to a major disease, but could influence. And when they started using SNP analysis in post-COVID, there were rare findings, but not a lot, and it was a bit disappointing. And so we've moved from the Mendelian to the SNPs using what's called genome-wide analysis using PCR technology. And then more recently, people said, well, wait a second, maybe we should be using analytic methods that look at the interaction of genes. And this is called computational genetics, where you actually look to see how this gene, is there a minor defect here that works with another gene to actually have an expression. And when they did that, they started finding in chronic fatigue illness, post-COVID vaccine fatigue, and post-infection fatigue, very similar genetic abnormalities. And this to me was a huge breakthrough. And there were clusters of these. And the clusters tended to relate to two different biological aspects. The first was the development of an immune response. And that made a lot of sense. You know, we've got a cluster of these interactive gene abnormalities related to not making a great immune response to get rid of that spike protein or the Epstein-Barr virus or the Ross River virus or CMV virus, any of these other viruses that can cause a fatigue illness. But they also found a second cluster which related to defects in mitochondria. Now, mitochondria are little tiny organelles in the cell which are like the batteries of the cell. This is where you generate the energy. You make it's like a bouncing electron chain, and these electrons bring together phosphate bonds that are high energy, and they can be used by the metabolic processes of the cell. And so this was really, really exciting, because for the very first time, there's a potential mechanism of the major symptoms that characterize every person, with pretty much every person with chronic fatigue illness, no matter what the cause. And that is energy activated fatigue. So if you've got a lousy battery, then the energy, particularly when you're stressing it by wanting to use it in muscles and whatever, makes a lot of sense. I'm not saying this is the cause, but to me, I found that extremely exciting. And the other really important thing is the same clusters of genetic abnormalities were present in those who got post-COVID infection, long COVID, following post-COVID vaccination, and in people with chronic fatigue illness. Not identical, but very similar. So all of a sudden now, the story is starting to evolve that as a result of clinical, metabolic, and genetic studies, we've got this phenomena. People are born with a proneness, if you like, in certain circumstances to get a fatigue illness. And so it's not surprising that when you've got something like messenger RNA vaccines, which cause a persistent antigen, and you've got a nasty virus that's likely to get expressed on a longer term basis, that you're going to get up to 5 to 10% of people getting chronic fatigue illnesses, plus, of course, the structural problems due to a second type of immune response to these persistent antigens. Does that make sense?
It does. So we have these, one or several of these single nucleotide polymorphisms, the ATCT, ACGT letter could be switched.
TACG.
Several of A, T, C, and G, yeah.
Thymine, adenine, cytosine, guanine, yeah.
Yeah, exactly, yeah. I always remember it's A to T and C to G. That's how I remember it.
I won't tell you how I remember it, John. I took a year off in doing medicine. I did a Bachelor of Medical Science research, and we were doing really the first messenger RNA analysis in metazoan multicell systems, and I had to work with chickens. Chicken egg, embryonic, 12-day-old embryonic chicken eggs, and I never, ever can eat an uncooked egg anymore. But one thing I did learn was the base ratios of nucleic acids, and that was in 1963, a long time ago.
Wow, some of the pioneering work into RNA. That's amazing. But what is now becoming obvious, really, is this computational genetics, where it's not a single gene or even 2 genes or 3 genes or 4 genes. It's the whole interaction, genes, some genes switching on, some genes up-regulating, some genes down-regulating. Yeah. And it's almost like a complex emergent biochemistry that emerges from this from this whole thing giving varying degrees of predisposition. It makes perfect sense. What I would like though is some way to up-regulate the immune system, so that the body itself can down-regulate the spike protein production. Any way we could possibly do that?
Well, as you possibly know, I have certain views on all of this, and that is that I think we're taking some concerning routes in how we manage conditions like COVID. I think probably the biggest mistake we made was to. I'm an immunologist, so I'm all for vaccination. But I think what we did here, and I'm not buying into messenger RNA. I've obviously got views on that too. But I think that what the history of biology showed us from 80 years of flu vaccination is that the vaccine will never be a central component, the central component for managing a pandemic to an inhaled virus, because you're straight away looking at trying to overcome the biology of two separate systems. You're injecting one and you're getting infected in the other, and they don't talk to each other very much. And when they do, you get incredible suppression coming from the mucosal route. Now that was all known right at the beginning. The vaccine was never going to be the central component, and so
the vaccine's only working systemically.
Yeah,
it's not working where the virus gets in the mucosa.
Their impact is important because they will help when that virus gets into the gas exchange part of the body in the lungs. That is handled by the systemic IgG circulating T cell response. And so there is no argument from me that you do get benefit against serious disease. But it's
well, you did in the early stages at least. I'm not sure it will work.
The vaccine producers have never ever kept up, and in any case, the vaccine's got other issues. So what I'm really saying is that I don't think that is going to be any more productive than we have had over 80 years of flu vaccine, and that's the Chinese vaccines are just as good. The Australian vaccine produced at Flinders University is just as good at preventing without the dangers, but they're not going to change the course of the disease. They won't affect getting infected or giving the infection to someone else, because you're vaccinating inside the body, not the mucosal surface, which is talking about getting infected and getting other people infected. So you have to think of something different. Now, the way we've thought about this is that trying to answer the question, why is it that if you get 100 people getting a virus, flu or COVID, 95% really do very well. I've had COVID twice or have treated myself, but even so, my whole family, none of us have got particularly sick. But I've got friends who have got very sick. And I know, obviously, of people who've died from this. It's only a small percentage. But when you start off, we're all sitting there in a room. We all look the same. We think we've got the same immune system, but we don't. So what is the difference? So my group, over many years, we've been looking at where there's a difference. And what we showed was that the way the body protects itself against these inhaled virus is by swallowing the virus, and there are little organelles in the lining of the gut called Peyer's patches. They're like little lymph nodes, and they're little organelles or organs, and they make T cells and B cells, antibody-producing cells, the B cells and the T cells, and they then go through the bloodstream to the lung. The lung is a very clever organ. It doesn't want to be bothered with having to learn how to protect itself. All it wants to do is put oxygen into the body and take the carbon dioxide out. That's what the lungs are there for. They do a few other things, but that's really what they're there for. And so they, if you like, have this off-site system where you make all the immune cells and you tell them what to do by swallowing what you've got. We're sitting here, John, if we sat here for 24 hours, and I won't do that to you, we'd swallow at least a cupful of secretions without knowing it. And of course, all the bugs that we have are in that cupful of secretions. Now, what we found is that 1 in 4 people do this process very inefficiently. And we can make that far more efficient by actually feeding one of the bugs that make this system work well. It's so simple. It's so ridiculously simple. And yet what it does, it dramatically changes the way in which the airways control an infected virus or a cell, so that you actually look at the idea of immune resilience. And while immune resilience is not something that's easy to measure, it can be done. Some people are over here, and if you can push their resilience over to the other side, you're actually preventing them getting serious disease. So my view is that what we have to start doing a lot more is looking at making people more able to resist getting serious disease, using what we do know about the biology. And this is something, obviously, my group and others, I hope there's others, seriously looking at, so that we, when a pandemic comes, no matter what that pandemic is, you've helped that person respond to the pandemic in a milder way than they would have if they were sitting there without, by making their process, physiological process, far more efficient.
And this will boost their mucosal immunity, whether it was a bacterium, whether it was a virus, whether it was something cooked up in a lab in Russia or wherever. It would just increase our ability to resist inhaled mucosal surface exposure to antigens.
Exactly.
Just
We've been developing this for 40 years, really, and we've shown that in people with chronic damage to the lung, people with COPD, emphysema, we actually reduce admission to hospital by up to 50% in people who have got chronic cough and sputum. We're called exacerbations there. When they get a virus infection, they get an exacerbation. And that's the thing that puts these individuals into hospital. We can halve that by making their process work more efficiently. We've now started thinking much more about, as a result of COVID, the normal healthy so-called healthy individuals, but particularly people with risk factors like smoking, older age, who could do with improving their delivery systems.
And we are not short of people with acute exacerbations of chronic bronchitis in hospitals. We have.
Well,
we've got plenty of those. I mean, the surgical wards fill up with them every winter, and surgical patients don't have space to fit in. So 75% of us aren't really very good at this. 75% of us are sitting there swallowing these bugs.
No, 75% of us are very good. It's the
75% are very good.
Yeah.
25% aren't very good.
Yeah.
But we all get a boost if you increase the number of bugs that we're swallowing by giving these attenuated bacteria to swallow. That's going to give everyone a boost to some extent.
That's right. Exactly. What we're doing is shifting the resilience. So we're making them more able to control the response to an inhaled virus, be it a flu, a coronavirus, or whatever.
So interesting questions there. Very obvious questions, because I can think of some of them, and obviously you've thought about these in more detail. Things that could easily be tested with basic laboratory testing, with I think pretty basic research techniques. We're talking about pretty basic prospective research methodologies here, and these things could be completely answered if there was the will to do so.
Yeah, it's interesting. I think about this a lot. What I've noticed is that science has been dominated increasingly by people doing PhDs in maybe a single cytokine, a single chemokine, and the literature is peppered with fascinating observations in the lung. Why have they got these funny cells? what is not happening is that young scientists, and unfortunately some of the people who are responsible for the training, don't seem to understand that you need to understand the big picture. You need to understand the broad physiological framework so that you can interpret and understand the specifically identified abnormalities, like a particular chemokine. And what is a Th17 cell suddenly found in a lung? What does that mean? Well, if you don't understand that that's the cell that's being delivered from the Peyer's patches, I mean, it sounds so basic and simple, but it happens all the time.
Yeah. Well, that and in combination and in combination with the fact that a lot of research is done for commercial ends. A lot of research is done by people that can afford to pay for it, or companies that can afford to pay for it. That kind of epistemological problem that you've identified, and this sort of I don't know what you would describe it as, an unfortunate financial situation. There's a deficit between the money to sense ratio in a lot of these situations, and
yeah, it's hard, isn't it? It's the way in which
short-term commercial interest.
Yeah, I mean, we're responsible for allowing this to happen. We've, a company, they see their responsibility as they're focused on rewarding shareholders, and they're going to reward shareholders by having a patented product. It doesn't really matter, in a sense, from the shareholders' viewpoint, whether it's very effective or not effective or causes more damage. It's going to be sold at great rate. I mean, let me give you an example. I'm just writing a thing at the moment on different ways of really repurposed drugs, and this is data that's in the literature that the cost of saving a life with ivermectin in COVID is $25 a life. Now, I mean, this is a terrible way to look at medicine, but just to give you an idea, the cost of saving a life with Paxlovid or molnupiravir, not that there's too many lives saved with them, but is $1,500. $1,500. No, actually, no, it's more than that. It was more than that. It was much more than that. I can't. But we're talking about.
It's probably it'll be that for a course, a short course, I would think.
$25,000. No, it's 25.
That sounds more like it.
Well, no, 150,000. I mean, it was massive amounts of money. Massive amounts of money. Now, this is all based on relatively objective analysis.
Even if these drugs are absolutely brilliant, which of course they're not, but even if they were brilliant drugs, the cost precludes whole swathes of the world's population.
Well, that's right, absolutely. I mean, we look. It's interesting looking at the big studies that are coming out with these specific antivirals. With their patents. They're all repurposed drugs, by the way. They're not brand new, wonderfully identified drugs because of COVID. They've been tried out in flu, they've been tried out in HIV, found to be pretty ineffective. So they recycle them, but they've still got their patent. Now, there's a big study showing that Paxlovid, which was probably the better of the two, has zero impact in resolution of symptoms or prevention of going to hospital. Now, that's with the current isolates. So in other words, the earlier studies which showed some benefit, even that was argued by many with the Paxlovid. But the early studies in your country, John, with molnupiravir, looking at 25,000 patients, I think it was the Oxford group that did this, zero effect. And yet every family practitioner in Australia is writing scripts for these every day at $1,200 a time. I mean, it's just, and it's worse than that because of the problems that are being seen with some of these people with the antivirals. And no one seems to want to talk about it or do anything about it. It shows you a power.
Yeah, with ivermectin, we've got this obvious example, and in acute and chronic. And
that's right. I mean, nothing's perfect.
Again, In treating your patient, I think you got down to 12 milligrams twice a week. Really, really
Well,
very
certainly
small
some of the
dose.
people, when they stabilise, these are the post-COVID damaged patients. What we do is we titrate to see how little you need. Because remember, this is all new. We haven't. This is a new problem, and no one wants to be on a drug for a long period of time. But I think what it's showing is that if ivermectin is acting the way that people like David Shine are showing, then that as long as you need it, all it's doing is preventing the immune response getting to the spike protein. That's how long the spike protein is sitting. It's an indirect index of how long the spike protein is persisting.
Yep. And you mentioned there, Robert, that a lot of this is new, but people like yourself who've got a lifetime's experience in research and treating patients, who a lifelong physician and consultant physician, researcher, you're in the ideal position to transpose your existing medical knowledge onto this new condition. And as a result of that, it really disappoints me that more people aren't listening to people that are able to synergize the old and the new together, like yourself. And it just seems the height of arrogance not to listen to people with high levels of medical, practical, and theoretical experience. We just seem to be in a bizarre situation. Why do we bother having professors if we're not going to listen to them? It really is.
Well, this one's a bit of an ex-professor these days. But look, I don't know. I can't talk about myself, of course. But what I can say is that it's fascinating to look at the decision tree, the individuals involved in making decisions as you go down through all aspects of any medicine, but particularly now it's COVID, where you've got this incredible overpinning financial and political components. I was looking at the reports that were contributing to this outcome of the government investigation of post-COVID syndromes, and the individuals giving it were well-meaning physicians, but I don't think there was one immunologist, I didn't see anyone I recognised as having an understanding of the process of the disease. And so you're seeing, if you look at the long COVID clinics in our hospitals, they're being run by rehabilitation doctors or respiratory physicians, all of whom are important, and I would never underpin or knock the importance of rehabilitation in managing many of these patients with chronic severe illnesses. At all. But what I'm saying is that these were the individuals who seemed to be giving the information, and it's not surprising that a very competent person, politician who happened to be a very experienced paediatrician, who was chairing the committee. You can't expect him to have an intricate knowledge of the immunology of COVID, but he's getting the input from my colleagues. And that input's important, but there was no input from people who I thought understood the disease. And this is the same with all the decision-making components of the decision-making tree, that you've got public health physicians who are very good at aspects of public health, but quite frankly, I've yet to meet one that really understands the immunology of a mucosal infection. And yet they're the people we see on TV. Many of them haven't even got medical degrees, so they can't be expected to really understand these processes. And we're having a review at the moment of COVID, and an old friend of mine happens to be chairing that, who is fantastic. But she's not a physician, not a scientist, and the two people assisting individuals who are a long way from understanding the biology of the disease. So. What can I say?
Yeah, well, we are biological entities. When the physiology goes wrong, that becomes pathophysiology, and there's no substitute for understanding those mechanisms and then applying those to the clinical pictures that we see. It's not something that can be dispensed with.
There's a resistance. We have a thing called APRA, which is it's a commercially run organisation for supervising the registration of health professionals. Now, I looked at APRA being they were making some pretty silly decisions, and I thought, well, I'm one person in this country who has a background of understanding this type of problem. So on 2 occasions, I contacted them and said, look, I'd be very happy to help you. I mean, I'm not trying to be arrogant at all, because there are a lot of things I can't help with, but this was an area I could. I didn't even get a reply, not even a courtesy of a reply, and that was with 2. And that is a repeating pattern. I tried with several other organisations, and that's just the reality.
There's kind of an obtuse component to it, isn't there? Just a refusal to learn, lack of humility, arrogance, I suppose. It's a very strange climate.
I think what I've described as arrogant is having a bureaucrat telling me how to treat a patient. And this is getting a little bit away from what we've been talking about, but I got myself in hot water about 3 years ago when I wrote an article for a very interesting good journal called Quadrant. And I said, look, I wrote it at the end of 2020 and it was published in January of 21. And I said, look, this is what I think is going to happen as a person involved in the biology, all of which has basically happened. But I pointed to the value of repurposed drugs in a circumstance where people were dying and they were being told to go to hospital if they couldn't breathe and get oxygen. That was the way they were being managed. Now, I got into terrible strife over that. And we were having bureaucrats making decisions, people who wouldn't know a sick person from a non-sick person, or doctors who had never seen a patient for a long, long period of time, making decisions to basically support a vaccine as an experimental registration. And people died as a result of that. Now, to me, the greatest arrogance and shameful activities was to interfere with the relationship between a doctor and a patient in making a decision with an accepted, safe drug that had some common sense value of trying, because what harm are you going to do? And all of us use off-label drugs all the time to handle patients who don't fit into textbook. People don't fit into textbook descriptions. Textbook descriptions are you and me writing a book about a disease which seems to put together most of the problems, but every patient's different and needs to be treated differently.
Absolutely. Professor, as always, thank you so much. And next week we are hoping to have a guest on the channel. We won't say who it is at the moment because we're not quite sure whether we're going to get him, but it's going to be very interesting if we can get the 3 of us together. Do tune in next week. You won't be disappointed. And we'll have lots more interesting things to talk about. But for now, I'd like to say, Robert, really appreciate the fact that this is pioneering material that you've chose to release through this through this medium, which is absolutely brilliant. It's going from your experience to people around the world to consider, without having to go through the cumbersome process of writing papers. I mean, I know you are writing papers as well, but that does take much longer. So we really appreciate this sort of breaking medical news, really, being released in this format. Thank you very much for that. And,
well, John, I know you want to finish, but let me just say,
okay.
Let me just say one thing, that the part of the confused process that surrounded COVID has been the written information at one level with the legacy press, and at another level with the once trusted medical journals. Now, a lot of what we've talked about would not be accepted by journals that I've grown up with, that I've lived by, that I've paid for out of my own money, because I valued those journals. The level of corruption, I think, that has seeped into communication through the printed word, through the Trusted News Initiative with Legacy Press, with journals now that are charging thousands of dollars if you want to put an article in, because it's only the big pharma companies that can afford that type of money. It's a disgrace. And so, John, I think what you've done is you provided a third arm of evidence-based medicine, and this is respected across the world, as you hopefully know. And people like myself really appreciate the opportunity of saying things that we believe are really important.
Absolutely.
So we're grateful for this opportunity. Thank you.
And of course, the irony there is that you can now not get published in journals that you've been published in all your life.
I've got over 300 publications on a lot of this, but I know that they wouldn't want to publish a lot of the stuff we're talking about. It's not to do with the data. It's to do with a narrative that's been so oppressively, overwhelmingly influential. And I think people in the public they understand this better than one might expect.
And increasingly so.
Yeah, increasingly so.
Yeah. Well, I'm going to go to bed and you're going to start your day. So
I'll have another cup of tea.
Yeah, good idea. So for now, Professor, thank you very much, as always.
Great pleasure, John.